Hello everyone, welcome to my next session regarding postgraduate teaching in pediatrics. And today I'm going to deal with a topic which is not per se a pediatric topic, it's a child psychiatry topic. But as pediatricians, we need to know few basics of this concept and of this disease, which is very common actually, and we need to be aware of it so that we can detect early and treat early and help the maximum children. So as you can see the heading, today we are going to speak today about autism spectrum disorder. Okay, so autism spectrum disorder, I'll deal with in few headings. Okay, and the first heading which we are going to come is in clinical description. Okay, now what you need to know that autism spectrum disorder is a diagnostic category which was introduced in DSM-5. Okay, DSM-5, and it was replaced to replace pervasive developmental disorders, which was in DSM-4. This was in DSM-4. Okay, so to replace this pervasive developmental disorders of DSM-4, this included at that time the classification was like 2-3, like there was an autistic disorder, and there was Asperger's disorder. Okay, Asperger disorder, or pervasive developmental disorder not otherwise specified. Okay, childhood disintegrative disorder. Okay, so all this was included in DSM-4 as pervasive developmental disorders, but all these have now been replaced by a DSM-5 as an autism spectrum disorder. Okay, why was this change made? This change was made because the separate diagnoses were not reliably made, or they were not consistent over the time. Okay, so they were not consistent over the time and they were not reliably made. Okay, so the diagnostic criteria of ASD, which was made in DSM-5, focused on two key areas. Okay, two key areas are being focused on. One is social interaction and communication. Okay, social interaction and communication, and other one is behavior, interests and activities. Behavior, interests and activities. Okay, now what you need to know is, although there is no longer a specific age of onset criterion for autism spectrum disorders, the symptoms must be present in an early childhood. Okay, and the most often the symptoms of ASD manifest in the second year of life. So this important point you need to know, most often manifest in second year of life. Okay, now what you need to know is a childhood history of completely normal social development, intact communication and age appropriate peer relationships will definitely exclude a diagnosis of ASD, or make it very unlikely that the diagnosis is ASD. Okay, like a childhood history in which there is normal social development, intact communication and age appropriate peer relationships are maintained makes it unlikely that the diagnosis is going to be ASD. Now what you need to know next in this clinical description is the DSM-5 criteria we'll mention in brief, will not go in detail. DSM-5 criteria for diagnosis of ASD. Okay, what you need to know is there are 5 components. Okay, there are going to be 5 components. We'll label them as A, B, C, D and E. Okay, there are 5 components of the criteria. Okay, now what is the first criteria? The first criteria says there should be persistent deficit in social communication, and social interaction. Okay, social communication and social interaction across multiple contexts, and it can be manifested by history, or for example, I'll tell you, there's a deficit in social emotional reciprocity. Okay, abnormal social approach of the child. Okay, reduced sharing of interest, reduced emotion, reduced affect. Okay, there's a deficit in non-verbal communicative behavior, like there is no abnormality in eye contact. Okay, abnormality in body language, or deficits in understanding and use of gestures. Okay, all these come under this. Even deficits in developing, maintaining and understanding relationships, okay, is also a part of this persistent deficit in social communication and interaction. Okay, now this okay, yeah, then coming next to the next second criteria. So in the first criteria, even there will be a total lack of facial expressions in the child. Okay, facial expressions won't be there much. In the second criteria says restricted repetitive patterns of behavior, interest or activities. Okay, and in this there can be any 2 of them, like out of 4. The first one being stereotyped or repetitive motor movements. Okay, use of objects and speech. Okay, or insistence on sameness. Sameness means inflexible adherence to a routine. There is an inflexible adherence to the routine. The child wants to do the same thing again and again every day, or we can call it a ritualized pattern of verbal or non-verbal behavior. Okay, and the child may have extreme distress at small changes. If there are even small changes, there may be extreme distress and any difficulty in transition, like there's a small change in his life and he's not able to adjust easily. There will be a rigid thinking pattern in the child. Okay, and he wants to eat the same food every day, or take the same route in the route to the school, or route to anywhere else. Every day he wants to take the same thing. He doesn't want to he doesn't want to make any change or transition in his life. Okay, number 3 would be a highly restricted fixated interests, which is like strong attachment to unusual objects. Okay, there's a strong attachment or preoccupation with unusual objects, and all this is called as highly restrictive fixated interests. And then the fourth one is hyperreactivity or hyporeactivity to a sensory aspect of the environment, like if there is an indifference to pain and temperature. Okay, indifference to sound or textures. Okay, or smells. There is no visual fascination with lights or movement. There is some hyperreactivity or hyporeactivity to this. Okay, and there is an unusual interest. So this all comes in the second criterion, that is restricted repetitive patterns of behavior, interests and activities. Okay, this is about the second criteria. The third criteria is the symptoms must be present in the early developmental period. In the early developmental period, symptoms must be present, but it may not become fully manifest until social demands will exceed the limited capacities. Okay, so sometimes what happens, like we told most commonly in the second year of life it manifests, but sometimes what happens, because the social demands are less in some situations, in some families or in some cultures, the child may not manifest early. You may not really understand that he's having any problem. Okay, So when the social demand will exceed the limited capacity of the child, that time it manifests. So but it should be present in the early developmental period. Okay, that is the third criterion. What is the fourth criterion? These symptoms should cause clinically significant impairment of social, occupational or other important areas of functioning. So there should be a clinically significant impairment. Clinically significant impairment. Okay, in what? Social, occupational or other important areas of functioning. Okay, and the last criterion, that is the fifth criterion, is all these disturbances in him should not be better explained by an intellectual disability. Not explained by intellectual disability. Okay, intellectual disability or a global developmental delay. So these things should not be explaining the disturbances. Okay, so that is the main thing about the criterion of DSM-5 criteria of autism spectrum disorder. What else can I mention? Few points I need to mention again in this clinical description. I want to mention that social deficits are the most consistent and reliable indicator of ASD. Most consistent and reliable indication of ASD. Okay. So what can it be? Sometimes like children will prefer solitary games. Okay, and they relate to others primarily as objects in their play. They will not be accepting that this is a person. They'll be referring to others primarily as objects in their play. All right, and sometimes what happens in younger children, you may see they will fail to seek out any peer interactions. Okay, they don't want to interact with other peers. Okay, and in older individuals, they may express an interest in friendships and seek interpersonal experiences, but they will lack the skills to initiate and maintain the relationships. So in younger individuals, they may not want to make friends, and their older individuals, even if they're trying to make friends, they are not so successful in the skills to initiate and maintain the relationships. So this may be one of the problems in them. Okay, and in many children with ASD, what you need to know, other problem is spoken language is either delayed or absent. In many children, delayed or delayed or absent it can be, spoken language. Okay, even in patients with normal language and IQ, there will be deficits in pragmatic language. Okay, so pragmatic language deficits may be present. Okay, like they cannot initiate or sustain a reciprocal conversation. Like you're asking something, the child is not responding to you, or child is not responding appropriately. Okay, now the communication may be characterized by echolalia. Okay, echolalia, pronoun reversals, scripted or stereotyped phrases. Okay, all these things, they may be there present in this spoken language of the child. Okay, and the child won't be there'll be an impairment in the socio-cultural meanings of the words he's having, or pragmatics, that is rules of interpersonal exchange, will be abnormal. Okay, and non-verbal aspects of communication like eye contact, facial expression and body language are not exactly normal in these children. Okay, what you need to know is many individuals with ASD will have a subnormal intelligence. Subnormal intelligence. Many of them will have subnormal intelligence. But what you need to know is some individuals have unusual or special capacities, like in music, drawing, arithmetic, calendar calculation. Okay, in some skills they may be like really amazing. Okay, so so some individuals will have unusual or special capacities. So these ASD people are called as savants. Okay, this is all you need to know for now about the main important clinical description of ASD. Okay, coming next, I will go ahead with some parts of epidemiology, just a few points. epidemiology, what you need to know is the prevalence is increasing. Why is the prevalence increasing? We don't know exactly, but most likely primary cause of this is that there is more awareness and the diagnostic criteria are becoming better. So what you need to know is increased prevalence is being reported from 1 year to each year. As we are like going ahead in years, we are finding that there is an increased prevalence of ASD. So what has been attributed as the main causes for this is, first thing, awareness is more now, okay. And the second thing what you need to know is broader diagnostic criteria are being applied, okay. Then what you need to know is there is a male predominance, that is male is to female ratio is 4:1, okay. And if you see in ethnicity, what you need to know is white children are more likely to be diagnosed than Hispanic or black children, okay. So this is what you need to know about the ethnicity. Now coming next to, after doing epidemiology, I'll just mention a few parts of in few aspects. I'll just explain etiology, what has been explained. Now ASD, what you need to know is a highly heritable condition, and it has multiple implicated genes. Okay. It is told that the prevalence of autism in siblings is 4.5%. Prevalence of autism in siblings is 4.5%, okay. And they have found that monozygotic twins have a higher rate of concordance than dizygotic twins, and this is implicating the role of early developmental biological insults. So why I'll explain what this point means. See, they are saying monozygotic twins are having a higher likelihood of having ASD than dizygotic twins. That is okay, but it's not 100%. But that risk is not 100%. Means what? It's not necessary that if the child is going to be having some genetic factors which are going to cause him to have ASD, 100% he will develop ASD completely in that severity. It's not compulsory. There are some environmental factors and biological insults which are happening in early life. Definitely that is also part of ASD. So what you need to know, genetic basis is there, definitely yes, genetic basis yes, plus there are early environmental biological insults involved, okay. Now what are some known medical conditions which can cause ASD or to have ASD? Known medical causes include Fragile X syndrome, which is 5% of ASD individuals, tuberous sclerosis, and certain chromosome abnormalities, okay. And some identified risk factors I'll mention: advanced maternal age or advanced paternal age also. Advanced paternal age, a sibling with ASD, okay, extreme premature birth, okay, and closer spacing of pregnancies. These are known identified risk factors, okay. Now very long ago, I mean in the sense until few years back, there was a thought, or there was a hypothesis that maybe some vaccination is causing ASD. So they used to say sometimes MMR vaccine, okay, or vaccine preservative thiomersal. These were, having a risk of ASD. Some people challenged, but many multiple studies have proved this to be wrong. Okay, so not related to vaccines, not related to preservative thiomersal. It is a what can you say? It's a belief. It's a belief by some medical professionals. Okay, they may believe it to be true, but studies have not shown it to be true. Okay, so what you need to know, MMR thiomersal is not related to it. Okay, so you don't tell anyone don't take this vaccine because you'll get autism. Okay, there is a lot of anti-vaccination revolution going on in many Western places. Parents are saying no, we won't vaccinate our children. We are against the concept of vaccination. It causes autism. All these things. So don't support all this. Vaccination is compulsory for every child. It's a right of every child, and it's the duty of every parent to get their child vaccinated against all deadly diseases, including MMR. Okay. Now, what you need to know after this etiology, I'll discuss a bit about course and prognosis. Course and prognosis. Okay, so ASD is often apparent in early infancy. Okay, it comes in early infancy, but in some patients what happens, the full disorder does not appear until the age of 3 years or so. Even after 3 years also some parents may notice changes. Until then they may feel that the child is normal. An initial period of seemingly normal development may be followed by developmental arrest or by regression with loss of previously developed abilities. So there may be an initial period of normal development, seemingly normal development, apparently normal, that is apparently normal development, and this is followed by a period of developmental arrest or developmental regression. Okay, that is loss of previously developed abilities. Okay, now the children with ASD will make gradual but erratic improvement, particularly during the school age years. Okay, occasionally the patients make rapid unexplained developmental progress. Okay, and the medical illnesses and environmental changes may precipitate behavioral dysregulation that may include compulsive behavior, aggressive behavior, self-injurious behavior. Okay, and this occasionally requires pharmacological intervention also. All right, so you need to know that medical illness and the environmental changes can precipitate some behavioral dysregulation, which may include aggressive, compulsive or self-injurious behaviors in the children. Okay, now you need to know that there are some comorbid conditions which may be present with ASD. What are those comorbid conditions? ADHD, anxiety, depression, motor incoordination, constipation, okay, and epilepsy, avoidant restrictive food intake disorders, sleep disorders. Okay. Now, what are the predictors of good outcome? Predictors of good outcome in ASD. Okay, higher IQ of the child, good outcome. Better language skills, good outcome. Okay, better language skills, good outcome. And greater social skills, good outcome. And later appearance of symptoms, okay, good outcome. Predictors of good adaptive outcome, these are. Okay, and what you need to know is next, this is about the course and prognosis. The next thing I'll mention is about evaluation of a child. Now what you need to know, the evaluation of a child with suspected ASD is a multidisciplinary approach. Okay, and the American Academy of Pediatrics is recommending that all children should be screened for ASD between the 18 months to 24 months of age. Okay, that is between 1.5 years to 2 years you should screen all children for ASD. Okay, and there are many screening tools which are available, out of which famous ones I will mention. Okay, so for screening, I'll now talk about tools. In this evaluation, we'll be talking about screening tools, clinical diagnostic tools, and research diagnostic tools. I'll tell you what each means. Now, screening tools is like brief screening instruments which can be used by primary care physicians or nurses, okay, with very young children. Now, example of the screening tool is CHAT, that is checklist for autism in toddlers. Okay, now this was then later modified, okay, to make into MCHAT-R, that is modified checklist for autism in toddlers. Okay, so if ASD suspected, adolescent psychiatrists, psychologists, developmental pediatrician experienced in assessing children with ASD are contacted, and further assessment is done. Okay, then later for diagnosis, standardized diagnostic checklists which are available are, most important one is one only I'll mention, that is CARS-2. CARS-2 full form is Childhood Autism Rating Scale, which is second edition. This is being followed, which is based on clinical observation and parental recall of early behavior. Okay, but this cannot be used as a gold standard instrument for autism diagnosis and research. In research, we use ADIR and ADOS. Okay, what is ADIR? Autism Diagnostic Interview Revised, and ADOS is Autism Diagnostic Observation Schedule. Okay, this was developed by the Lord and colleagues, and this is available from Western Psychological Services, that is which you can mention. But what you need to know is, now this is a very important tool which you are following, MCHAT-R, as a part of NCECD. Okay, that is nurturing care for early childhood development, early child development. We are using this MCHAT-R, which I am going to show you here. What is this MCHAT-R, which is a screening tool? This is MCHAT-R. Okay, see what does it say. Please answer these questions about your child. Keep in mind that how your child usually behaves. If you have seen your child do the behavior few times, but he or she does not usually do it, then please answer as no. Please circle yes or no for every question. Okay, so there are questions, like 20 questions here. Okay, and the total score like you add one and you add one for all no's except for, I'll tell you, except for 2 and 5 and 2 more were there. Okay, I'm not able to recollect. So the total points, based on the points, we are able to like assess whether the child is having a risk of autism. So what do? We take this checklist and we assess with the mothers. Okay, okay, so if we get a score of 1 to 2, this is low risk. Okay, for moderate risk it's 8 to 20. Sorry, it's 8 to 2 to 8 is moderate risk, 3 to 8 is 3 to 7 is moderate risk. Moderate risk is 3 to 7 and 8 to 20 is high risk. So only a score of greater than equal to 8 is eligible for more clinical evaluation. If it is a moderate risk, you should again review after 6 months and check again. Okay, so this is about the MChat R scoring tool, okay, which is very good, easy tool which you can use handily, very easily in your OP to assess the risk of ASD. Okay, coming next to the next part of the discussion which we are going to do. Yeah, I told you about the tools, right? Next we will discuss a little about the differential diagnosis. Sorry. I'll discuss a little about the differential diagnosis. There are many differential diagnoses which you can say at this point. Number one, Rett syndrome, you should know. This, but what you need to know, this occurs predominantly in females. Okay, and includes deceleration of head growth. There is marked intellectual disability. There are hand washing stereotypes. And loss of purposeful motor skills. Okay, that is about Rett syndrome. Second, what we need to know, congenital deafness. In congenital deafness, deaf children typically learn an alternative oral or sign language. But these autism spectrum disorder children will appear deaf. Because why deafness? Because they don't respond. When you call out their name, they don't respond. They don't look at you. So that's why congenital deafness has come as a differential diagnosis. So but deaf children will typically then definitely learn an alternative oral or sign language, and they lose their isolative behaviors and develop expressive communication slowly. Then they learn alternative. How do you differentiate? Learn alternative oral or sign language. Okay. Number 3, you need to know about congenital blindness. But blind children will relate socially. Then developmental expressive and receptive disorders. Developmental expressive or receptive disorders. In this, what happens? These children are typically more sociable, communicate well with gestures, and do not have stereotypical and repetitive behavioral patterns. Okay, no repetitive behavioral patterns, and they develop good social skills, but they have a developmental expression and receptive language disorder. Okay, then next is juvenile onset schizophrenia or schizophrenia, or however you pronounce it. Juvenile onset schizophrenia, and this is distinguished by hallucinations, okay, delusions, and thought disorder. Okay, and children with pure intellectual disability can also be taken as one differential diagnosis. Okay, but in this you need to know that they have a lot of global distribution of delays and fewer abnormalities related to their behavior, but a lot of problem with developmental delay. Global distribution, global developmental delay will be there in them. Okay, and then another differential diagnosis is reactive attachment disorder. Reactive attachment disorder in very young children. In very young children, you can consider reactive attachment disorder, but this disease or these cases are typically characterized by history of severe neglect. History of severe neglect will be there in them. Okay, so reactive attachment disorder is there one. So if there is history of severe neglect in a child, he may develop some symptoms which are similar to ASD. Okay, but there will be history of severe neglect in them. Okay, then in selective mutism, there is something called selective mutism in some children. The patient is able to speak in certain situations, such as in home or familiar adults, but if someone new suddenly comes in front of them, they'll become completely quiet. So they speak well with familiar adults, familiar people, they speak well. selective mutism. Okay, and then one more thing what you need to know in last two, I am giving you 10 differentials. One is called degenerative neurological diseases like Landau-Kleffner syndrome. Landau-Kleffner syndrome, which is acquired epileptic aphasia. It may resemble ASD to some extent. And the last one was social communication disorder or pragmatic communication disorder. Pragmatic communication disorder. Okay, in this what you can do, it overlaps with ASD in the domain of social interaction and communication, but there is no restrictive repetitive behavior and interest. No restrictive repetitive behavior interests. Behavior or interests in these children. Okay, so this was about the differential diagnosis which you need to know, which you can write for a case of ASD. Now next, coming to the last heading, which is the treatment. What do you do for the treatment? Okay, what do you do for the treatment? Now, the patients which are fortunate enough to have early access to multidisciplinary treatment will show a significant improvement. Okay, and the environment in which they should be treated should be a very highly structured environment. Okay, and this includes special education, speech and language instruction, vocational training for adolescents, and teaching of adaptive skills. Okay, so this is the 4-prong treatment, that is special education, speech and language instructions, vocational training for adolescents, and teaching of adaptive skills form the 4 prongs of the treatment. What can behavioral therapy do? Role of behavioral therapy. Behavior therapy will reduce the unwanted symptoms. It will promote speech, it will promote social interaction, okay, and increases the self-reliance in the child. Self-care skills are improved, okay, and it facilitates exploration in the child as well. Okay, so the child's behavior therapy can help a lot in all this. So it improves the self-reliance, self-care skills, and facilitates exploration. Alright, parental guidance is critical in management of ASD. That is, because the parent have to provide education, and the parent have to deal with the emotional reactions of the child, such as guilt or denial also. Then parents will also contribute. How? Parents will also contribute in child's learning of language, in the child's learning of self-care, in the child's learning of adaptive skills. Okay, and the parents are the ones who can arrange for special education, okay, and other services, or make more long-term plans for the child as well. Alright, so this is about the parental guidance. Then acute hospitalization. I'll just mention one line about acute hospitalization or long-term residential treatment may be required in cases of severe aggression. Okay, severe aggression, you have to go acute hospitalization or long-term residential treatment also sometimes. Okay, and long-term OP follow-up is required for child with ASD. Long-term outpatient follow-up is required for a patient with ASD. That is periodic reassessment for comorbidities like epilepsy, mood disorders, or anxiety disorders you should look out for. So comorbidities you have to look out for. Okay, like epilepsy, mood disorders, anxiety disorders. Okay, if there are any coexisting psychiatric disorders, you may have to use psychotropic medications as well. Okay, and if a child is having few things I need to mention is, if a child is having ASD with ASD with ADHD. One may consider the treatment atomoxetine, which is a stimulant, okay, or alpha 2 agonist, that is guaifenesin or quinidine. And if there is autism spectrum disorder with depression or comorbid anxiety symptoms, SSRIs can be used, okay. But one should be very careful and titrating the cautiously and monitor for agitation and behavioral activation in the child, okay. All these things I've mentioned. And then one more thing which you need to know is I think one more thing which you need to know is about risperidone. Risperidone is a atypical antipsychotic. And low doses of this non-sedating antipsychotics in conjunction with, means mixed with, highly structured program may help control the behavioral symptoms and even reduce the excessive activity levels and enhance the effect of behavioral therapy which you are giving to the child, okay. So this is one point about risperidone, atypical mixed with a conjunction with a highly structured program, treatment program, okay. So this was about ASD overall, okay. So we discussed about what are the clinical description points and DSM criteria, epidemiology a bit, etiology, okay, course and prognosis, and evaluation, where we have three kinds of tools: screening tools, clinical diagnosis, and research diagnosis tools. We discussed a little about MCHAT-R and how it's included in NCECD program of program, and we discussed quite many differential diagnoses and how to differentiate it from the others, from ASD. And treatment, we have discussed about, you know, 4-pronged treatment and behavioral therapy, what is the importance of parental guidance, okay, and when do we do acute hospitalization in a case of ASD, and long-term OP follow-up for comorbidities we need to do. And what about the comorbidities, ASD plus ADHD, how do we treat, what can we add for treatment? ASD plus depression, and some management of behavioral symptoms can, along with behavioral symptoms, and as well as reducing the excessive activity levels and enhancing the effect of behavioral therapy which you are giving, you can add risperidone to the treatment, okay. So this was about the ASD. I know it is not as perfect as taught by a psychiatrist, but for pediatric postgraduates point of view, this is good notes. And the source is not mine, I am not telling on this. The source is concise guide to child and adolescent psychiatry, DSM-5 edition, okay, DSM-5 edition, adolescent psychiatry, and the publishers are American Psychiatric Association publishers, okay, written by Dalkin, Ballard, Jha and Sadhu, okay. So this is about ASD. The source of mine is an adolescent psychiatry textbook of DSM-5 edition, so need not worry about the information which I have given. All information is given in that book only under ASD topic, okay. This is Dr. Waheed Hussain, and I would like you to share this video with the ones who can make use of it, and please like and subscribe. Thank you very much. Good night.